You can, uh, Good morning, everybody. I hope you would have enjoyed the talk by Dr. Nageswar Rao, which was yesterday, and he spoke on the diagnosis of coarctation and the options with interventions. I'm going to cover again some basics of coarctation, followed by the surgical options. So there may be a little bit overlapping of our talk, but I think that makes sense since this is a topic that involves both cardiology and cardiac surgeons. So coarctation is from the Latin word coactio, that means a drawing or pressing together. It's a congenital narrowing of the upper descending thoracic aorta adjacent to the site of attachment of the ductus arteriosus. The aortic lumen may be atretic in most severe form, but aortic walls above and below the atresia are in continuity. This is very important, as distinguished from the aortic arch interruption, in which a short distance separates the aortic ends. So, if you look into the development of the aortic arch, it's very important to know the left fourth arch vessel becomes the arch of aorta, the left sixth becomes the part of the left pulmonary artery and ductus arteriosus. So, this is again development continued. So, the contribution of the arch of aorta is mostly by the descending thoracic aorta as well as the fourth arch, and the ductal part is by the sixth arch. This important part of ductal part by the sixth arch is the area where mostly you can see clearly this part from the fourth arch and this part from the sixth arch is the area for the focus of coarctation. That's very important for all of us to know. Now, how does the coarctation develop? This has been proposed by Skoda 100 years ago, and Russell, he actually did, he found circumferential sling of ductal tissue in almost 22 out of 23 specimens. What he found, there was muscular tissue of the ductus in the elastic aortic wall. So, due to a migration of ductus smooth muscle into the periductal area with subsequent constriction and narrowing of the aortic lumen, coarctation happens. And this is in today's world where we use a lot of prostaglandin, PGE1. This is evident when the duct closes, and this is the basis for treatment with PGE1. Now, the other theory is flow theory for coarctation. It's proposed by Rudolf et al. So, coarctation as well as isthmus hypoplasia is more common than usual when ascending aorta flow is diminished during fetal life, and the ductal flow is relatively increased by lesions such as aortic stenosis or atresia and mitral stenosis or regurgitation. Prevalence of coarctation is severely reduced and size of the isthmus is increased when pulmonary flow, and thus the right to left ductal flow is decreased by lesions such as pulmonary stenosis or atresia, tetralogy of Fallot or tricuspid atresia. Coarctation is uncommon when the aortic arch is right-sided, presumably because of the alteration of the ductal and ischemic flow pattern in this situation. So this is very important to know. So in all obstructive left-sided lesions, the chances of coarctation is more because the flow to that ischemic area or coarct area is less. And in all the situations where there is a flow restriction to the right ventricular outflow tract, the consequence of that is there is more flow through the left side, and so coarctation does not happen in situations like pulmonary atresia, tetralogy of Fallot or tricuspid atresia. Well, there are other theories also. So, by Capitin et al., they think it's due to a defect in the vascular wall of the affector because of the abnormality in the neural crest development. Mollin et al., they think it's vascular apoptosis. There is a recessive genetic mutation found in the zebrafish, which is reported by Weinstein et al. Coarctation is an autosomal dominant inheritance of non-syndromic left ventricular outflow tract obstructions, reported by Wegel in 2005. So it's also seen in autosomal dominant transmission at familial and it's in association with Turner syndrome. So it's very important for all of you to know what exactly is the nomenclature of different part of the aorta. So this simple picture again re-emphasizes that the part of the aorta between the subclavian artery, innominate artery and the left common carotid artery is called proximal transverse arch. The part between the common carotid artery and left subclavian artery is called the distal transverse arch, and the part between the left subclavian artery and the ductal insertion is called the isthmus. So in a coarctation, virtually these three segments are likely to be involved. That is very important for us to identify and have a basic common pattern of leveling each part of aorta and take measurements at each part to have a uniformity for decision making. Now it's very important that all these things happens around the duct. It's in the periductal area, and there is a shelf mostly in the just adjacent to the ductus arteriosus. So this shelf, it consists of an infolding of the aortic media with a ridge of intimal hypoplasia, and it includes tissue extending from the ductus arteriosus. Aortic isthmus is hypoplastic and may involve this also may involve the transverse arch. The coarctation segment has increased number of elastin laminae and has decreased number of alpha actin positive cells. Now, there has been enough study of this particular specimen where they found there is a posterior shelf, or it is called as posterior coarctation membrane. So in surgical way, we try, there is in patch aortoplasty especially, we try excising this surgically this posterior shelf, and this causes disruption of the intima and predisposes to aortic aneurysm formation. That's why this excision of the posterior shelf is no longer recommended. Now it's very important, if you have a coarctation or obstruction to the flow in the main part of this part of aorta around the ductus, obviously there will be collaterals that will develop between the proximal and distal arteries. So the arteries that they participate in coarctation are the collaterals from axillary artery, internal mammary or internal thoracic artery, and they join all the intercostal arteries below the coarcted segment. Important for us to know that coarctation happens almost in 5 to 8% of congenital heart defects. So it's like 5 in 1,000 live births. Out of the coarctation, isolated coarctation is almost 82%. And in that, the male to female ratio is 2:1. You have coarctation along with VSD present in almost 11% of the cases, and in other 7% cases, coarctation exists with other coexisting complex cardiac anomalies. And when you go for complex coarctation, that means coarctation with either VSD or with other complex congenital heart defects, there is no sex dominance. Now, survival in pure coarctation, 15% they present with CHF in neonate or infancy, 85% they will survive till late childhood without operation, 65% survive till third decade of life, and only 2% survive at around 60 years. They land up in bacterial endocarditis. Aortic rupture happens, though rare in second to third decade, and a lot of these patients they die because of intracranial aneurysm ruptures. So this is a curve that says about the natural history of coarctation. That means at age of 30 years, you have almost close to 60% of the population that 40% of the population that demise. So survival at 30 years is roughly around 60% without being at risk. Now coarctation, by the natural history or pathophysiology, it presents in a bimodal distribution. That means it presents very early in life, and subsequently it can present in the infantile and in the older kids. So the first presentation is usually in the first week of life, and this is because the blood flow to the lower body is dependent upon the ductus arteriosus in this case, and whenever the duct closes, the baby lands up in a cardiovascular shock, renal failure and acidosis. So what do you do in that situation? We will end up starting prostaglandin E1 that takes care of the ductal opening, as well as the coarcted segment also opens up since it contains the ductal tissue, These babies, they benefit from intubation and ventilation, inotropic support, correction of acidosis. Then one assesses the LV function. If there is severe LV dysfunction, then a palliative balloon angioplasty is done to further stabilize the child before being taken up for surgery on a semi-elective basis. Now the second way of presentation of pathophysiology or natural history, the second model or bimodal out of the second part is these babies or children, they present, or young adolescents, they present with proximal systemic hypertension. That means first time they present to you with history of headache, and when you try to take down the blood pressure, you find systemic hypertension in the upper limb, and there is a clear difference between the upper limb and lower limb pressure. Now because of the hypertension, one lands up in headaches and epistaxis. Because of, again, improper flow down to the descending aorta, you can have these babies or the children, they can have claudication from inadequate lower body perfusion. Most important to understand that along with the mechanical obstruction to the flow of blood resulting in hypertension, hypertension also happens because of baroreceptor mediated reactive pathway. And because the consequence of hypertension leads to circle of Willis aneurysm, aortic aneurysm, and very rarely aortic dissection. Now, I'm sure Dr. Nageswara would have covered a lot about diagnosis and way to stabilize the children. I just want to again re-emphasize this. It's important for you to know when does one intervene in coarctation, either by any intervention or by surgery. So it's important to establish a peak-to-peak coarctation gradient more than 20 millimeter mercury, and this is the difference in the peak pressure between the proximal aorta and in the distal aorta. So that means if you take the cuff pressure in the arm and cuff pressure in the leg, if the peak-to-peak gradient is more than 20 millimeter, then there is an indication for intervention in these babies or children. Now there can be situations where you have a coarctation and the peak-to-peak gradient either by Doppler or by the blood pressure measurement may be less than 20. But these children will also have imaging evidence of significant coarctation and radiological evidence of significant collateral flow. So that way, suppose for any reason you land up doing a CT scan in these babies and you find there are a lot of collaterals which have already developed, and the gradient you are getting by Doppler or by upper and lower limb blood pressure estimation is less than 20, then this has to be addressed in spite of the gradient being less than 20. That's because the resting gradient alone may be an unreliable indicator of severity when there is significant collateral circulation. So mind you, your 20 gradient is not sacrosanct. The other way of looking at the indication for intervention is when there is significant hypertension, when there is congestive heart failure, obviously, no questions, one has to intervene. Now neonates and infants who are symptomatic, they should have urgent intervention as soon as possible after the infant is stabilized. Now in asymptomatic infants, children, adolescents and adults, elective surgical or balloon therapy is indicated. And what has been observed that the indication now boils down to that if you have to do, you go ahead with the intervention or repair between 1 to 5 years. That is going to result in a very good long-term palliation of this particular condition. So overall management guidelines is for neonates with hemodynamic instability. First is stabilize with prostaglandin E1, and that can follow by surgery. For infants and older children, now in the first category of neonate, if there is severe LV dysfunction, then a palliative balloon dilatation is indicated, and subsequently after maybe a week or so, one can go in and do a surgery. For infant and older children, balloon dilatation is preferred nowadays, and in many situations, if the coarctation is not discrete, if it is long segment, then one can go ahead with surgery. Now for adolescents and adults, balloon dilatation with stenting is a preferred method now. For redo coarctation, especially after balloon dilatation or after the surgery, balloon dilatation and stent is the answer. For recurrent coarctation, where surgery is already done and it's not amenable to balloon dilatation or stent, then there are situations where you have to resort to alternate surgeries. Now I'll take you just grossly about few people or names who have contributed immensely in repair of coarctation. Well, coarctation was first described in 1760 by Morgagni. The first coarctation repair was done by Crawford and Nile in Europe in October 1944 after Crawford visited Boston Children and observed Robert Gross doing this experiment in the lab. So he applied it in the humans and did the first repair in 1944. Now excision and end-to-end anastomosis was reported by Linswiller, Kirkland and Mustard. Mustard is the first person, in fact, to report in 1953 in a neonate who was a 12-day-old baby. Now Vorsschulte in 1957 he proposed putting on a prosthetic on-leg graft or a patch. Subclavian patch aortoplasty was reported by Warleson and Narold in 1966, and Robert Gross in 1951 was the first to use a prosthetic tube graft. In fact, he used an aortic homograft to start up as an interposition in coarctation repair, and subsequently in Mayo Clinic they reported the use of prosthetic tube graft of Bacron in treating coarctation, which had a very long segment, and it was not possible to get an end-to-end resection and anastomosis. So with this, grossly for you people, it is important to know the varieties of surgeries available for coarctation is resection and end-to-end anastomosis. You can see that clearly. You resect out the end and you get it to the better part of the aorta. The second option is one can just cut across both the narrowed segment up and down and put a patch. The third option is a interposition graft if the gap is too much. The fourth option is using the subclavian artery as a natural tissue to pass the coarcted area and widen it. So I'm going just bit by bit in each of these methods that we normally land up using. Subclavian artery plasty. Most of the coarctation repair are done through the lateral thoracotomy. If there is associated cardiac defect, then it is preferred to do from the median sternotomy, where in one stage one can repair the, say for example, VSD or any other anomaly associated with the coarctation can be taken care from the midline using heart-lung machine, either by normal flow or total circulatory arrest. Now for isolated coarctation, in case of one opting for doing subclavian plasty, the preferred route is through thoracotomy, and it is through left fourth intercostal space. Now you can see in this picture, as soon as you enter over there, you see visibly the left common carotid artery, the left subclavian artery, and the descending aorta. So the pleura over that is incised, and then you can see in this particular thing, before the clamps are applied, this is the whole area that has to be incised first. The part of the subclavian artery, the part of the coarcted segment, and the part of the descending aorta. And one has to sacrifice one or two intercostals, as well as one has to tie up the left subclavian artery as far as possible. And after you do that, you turn this subclavian artery down and use this subclavian artery substance to take care of augmenting this part of the coarcted area with a 7-0 Prolin suture all in a continuous manner, so that whole part of the aorta becomes like a normal aorta. So essentially what you are doing, you are using the autologous part of the baby, the subclavian artery itself, and you are turning it down to repair the coarcted segment, getting a normal caliber aorta. Now there has been a report of another technique called reverse subclavian plasty. So what do you do in that? You essentially ligate the subclavian as far as possible. You incise this part of the subclavian, not the below part of the subclavian, rather the part which is adjacent to the left common carotid. There you incise, and this incision can be extended up till the left common carotid, and then this part is sutured in the reverse way, which will take care of the distal transverse arch, and subsequently the ischemic part and the periductal part is completely excised, and the aorta is mobilized, and this descending aorta with the good caliber is now anastomosed to the new proximal, distal arch part of the aorta, which is augmented by the subclavian in the reverse flap way, and that can have end-to-end anastomosis with the proximal and distal part, leading to a normal caliber aorta. So this is called reverse subclavian plasty. Now, people have reported also using the left common carotid artery also. It's not only subclavian. So there are situations where the coarctation at the periductal area is so severe that the whole of the distal transverse arch is narrow, as well as the subclavian artery is not in the position to be used. So in that situation, one sacrifices the subclavian artery. However, one can also use the part of the common carotid artery. So you divide the common carotid artery, you make a flap out of that, you turn it down to augment this part of the essentially called the distal transverse arch, is augmented by the common carotid artery. And when you get this to a better caliber after augmenting with the common carotid artery, the descending aorta is mobilized up, and the anastomosis between the descending aorta and the proximal aorta is done, which extends almost to the lesser curve of the aorta till ascending aorta. So this is reported by Elkins, which is called as a carotid artery flap. So the concern for all this technique of subclavian artery or carotid artery flap is possibility of limb ischemia, and of course, if you are using carotid artery, neuroinsufficiency. That's something to be kept in mind. Now, this is a simpler technique reported by Vorsschulte in 1957. So 67, and this whole thing is called patch aortoplasty. That means just incise across the coarcted segment into the good part of the aorta and proximal part also into the good tissue. And after doing that, some people end up in excising the posterior self, and otherwise you put in a patch, which is mostly a Vortex PTFE patch or a Dacron patch, and that is shown all across between this coarcted segment. So the new caliber becomes like this after the onlay patch is put. Well, there has been report of people using autologous pericardium, autologous treated pericardium, Italian group, and they have seen good results using that in babies. So same thing, just incise across the coarcted segment from the proximal part to the distal part, and in this thing use a oval shaped autologous treated rotated treated pericardial patch, and that takes care of the coarcted segment. Now the concern in both of these techniques is there is a possibility of aneurysm formation opposite to the patch, because where there is a weak tissue at the posterior self area, if that is touched or that weak tissue still exists over there. See, the whole essence of coarctation surgery is to ensure that the coarcted segment or the dirty tissue is no more there in the patient. That should be the idea of doing the surgery. So in this particular method, that part is still left, and that is posterior. So that may land up causing aneurysm formation, which has been reported pretty well in this type of surgery. So what we normally follow in today's world, if there is a short segment coarctation just around the duct, we'll end up dividing the ductus, we'll end up excising the tissue up and down, which is the coarcted tissue, essentially the ductal tissue extending into the coarcted segment, and then you mobilize the aorta, maybe dividing or mobilizing the intercostal arteries up, and then you get them end to end, directly tissue to tissue anastomosis with the 7/6 protein. And many people, especially our unit, will end up using interpret sutures anteriorly and posteriorly continuous sutures, so that there is some issue that the growth potential is there by use of interpret sutures. Now, in this technique, obviously, you can end up doing that and you can have a fantastic result initially, but there is always a concern of residual coarctation or decoarctation. Now, in arch hypoplasia, what is desired that this whole descending aorta after excision of the coarcted segment is mobilized up, and it is almost tacked to the undersurface of the arch with maybe another incision, a fresh incision at the lesser curve of the arch. So the final repair looks like this. So this we call as extended resection and end-to-end anastomosis. Now the concern is, well, it's easy to draw pictures like this and show it to you. It's not easy to do it on the baby. So the whole story is, it depends upon how much tissue you can mobilize, how you can get the distal aorta quite up to the proximal aorta. And in this technique also, the recoarctation rate, though it is low, it is still reported as 2 to 4%. Now this is a technique which is a little different modification of the same, which is a further aggression of the previous technique, which is called as aortic arch advancement. And this repair has been reported by Carlos Mary. So what they have done essentially, they have extensively mobilized the descending aorta, and after taking care of the huge duct, the distal isthmus is just tied up, and the aorta, after completely mobilizing it with sacrificing maybe 3 to 4 pairs of interposition artery, it is cut in this beveled way, and after making this bevel, this particular part of the aorta is anastomosed to the ascending aorta. Ascending aorta, in the lesser curvature of the ascending aorta, a new incision is created, and this particular part of the descending aorta is spatulated, beveled, and it's pulled up and anastomosed in a continuous manner between the ascending aorta and descending aorta, and this is how it finally looks to be. A normal caliber aorta, and this ascending aorta continues as the descending aorta, and all other cranial vessels, they come out as an offshoot of that. So, well, as I told you, it's easy to draw pictures, but the concern in this is left bronchial compression, which happens mostly in some babies with this particular technique. Now, we all know that it's easy to mobilize tissues very much in neonates and infants. Now, in older children, especially adolescent and adults, it's not easy to mobilize any aorta more than maybe 2 to 3 centimeters. So what do you do in that? So if there is a good segment of coarctation, and after excision of the coarcted tissue, you find the gap between the proximal and distal aorta is quite a bit. In that situation, one should think about using a interposition graft. Now this was described, as I told you, in 1951 first by Robert Cross. He used aortic homogram. In 1960, Norris, Pulley, DeBakey, and Crawford, they use of Dacron prosthesis interposition. And though it is not very frequently used, it is used almost like 3% of their 171 patients they reported in 1960. So here, after excision of the coarcted segment, you have the proximal part and the distal part, and the distance is too much. So to bridge the distance, this particular distance, one lands up in using a prosthesis which is like roughly around 3 centimeters. And this prosthesis, what is important, it should be of a good caliber, at least of 14 to 16 size, which will match to a bigger size or adult aorta. So the recommendation for prosthetic interposition graft is usually the age should be more than 16 years. There can be associated aneurysm, complex long segment coarctation or recurrent coarctation, and if the anastomosis one feels is going to be under tension, so there is too much of gap between the proximal and distal segment and one cannot mobilize that much, and the anastomosis appears to be under tension, then it is better not to go for end-to-end anastomosis, rather interpose a prosthetic graft, because what will happen if you do it under tension, then the aortic wall will thin out, which will result in post-stenotic dilatation and subsequently aortic aneurysm. Now, what is the concern in this? Can we use this prosthesis in all the babies? No, because there can be a patient prosthesis mismatch (PPM). So this cannot be done in neonates. It cannot be done in infants. It cannot be done in younger babies. Rather, it can be done only in adolescent or adults, where one can go ahead and use an adult size aorta, which at least is 14 to 16, depending upon the body surface area. Now there are situations where you cannot take care of coarctation in a normal way. you will find situations where people have gone in and dilated coarctation 3 times, 4 times. They ended up putting a stent, and the stent also not working. So those are the situations one goes for extra-anatomic aortic bypass grafting. That means you completely bypass that coarcted area. You do not go to that area. Rather, the aim is to establish a continuity between the ascending aorta and descending aorta by a anatomic pathway that is away from the coarctation. So indication is coarctation or re-coarctation and associated cardiac problem that require repair through median sternotomy, complex coarctation or re-coarctation with anticipated difficulties with direct anatomic repair. So these are the various ways one can bypass with using a prosthetic graft between the ascending aorta and descending aorta. And what is important is that if this has to be done under median sternotomy, this has to be done under bypass, support bypass, and the graft can be placed. The most preferred way of putting the graft is around the right border of the heart, so where the graft is taken from the ascending aorta and it curves around in the right atrium and it goes down and it reaches the descending aorta. In most of the situations, the descending aorta above the pericardium, above the diaphragm is the preferred area. So this can be achieved if, as you see in this particular case, this is the coarcted area, and this area is impossible to tackle in the natural way, even with any kind of stent or any kind of balloon dilatation or surgery in the natural way. So it is preferable to look at this ascending aorta and look at the descending aorta. So in that case, it is preferable to bypass the whole area using extra-anatomic pathway, and here a diaphragm tube is used 16 sides between the ascending aorta and the descending aorta. This is how the picture looks subsequent to the repair. Now these are the different varieties of surgery that is available for coarctation of aorta repair. Now what are the complications? You can land up in paradoxical hypertension. When you started off with hypertension and you have done a coarctation repair, there is still hypertension. So the reason for that is if one eliminates there is no gradient across the coarcted segment and the repair is good, then this hypertension is definitely going to come down after some time, since it is all virology mediated and it takes some time and treatment with antihypertensive treatment. But one has to ensure that the repair is good or there is no gradient between the proximal and distal aorta. Now paraplegia, it's a very dreaded complication of coarctation, reported less than 1% of the cases, but this was actually a historical complication. Of late we do not see paraplegia happening in a coarctation repair unless it's an adult and unless it is done without taking adequate care to take care of the spinal cord below the descending aorta or coarcted segment. Now very common and still persistent is recurrent laryngeal nerve injury. Recurrent laryngeal nerve injury happens when you dissect around the ductal area, and if one uses a lot of cautery and is not careful about protecting this nerve, then you will end up with recurrent laryngeal nerve injury, which will, especially this is more common in very young neonates and infants and also in adults. If one is going for a subclavian aortoplasty, then there is a chance of left arm ischemia. Well, like for any surgery, there is a huge chance of hemorrhage. It's being aorta. It's a very, very major common cause for any post-operative problems. Now, after coarctation, as I told you, there can be aneurysm formation in the site of repair also. The another persistent problem that we see in some of the babies is chylothorax. That's because dissection in that area, one may land up injuring the thoracic duct. Now, Horner syndrome, because of injury to the cervical sympathetic chain, which is again present in that area, very rarely, especially in neonates, one land up in phrenic nerve injury and causing diaphragmatic paralysis, which may require a diaphragmatic ligation subsequently. And of course, stroke. Now, the long-term complications, I would not call it complications, I would say residuals. So the long-term problems that we see in coarctation surgery are restenosis or recoarctation. And Again and again, I want to say coarctation is a surgical disease. It all is influenced by the presence of residual ductal tissue within the aorta after the repair. Hypertension, it's more likely to happen if one goes for a repair at a later age. So now, mostly if a coarctation is established, the repair is indicated between 1 to 5 years. Sooner the better. The whole idea is to have no hypertension in subsequent stage of life. Now, neurological abnormalities are seen. They are picked up more and more now because of CT scan, MRI, and other modalities available. Now, the special issue that one should know is systemic hypertension, and this has to be treated by, if the LV function is good, by beta blockers, or if there is LV dysfunction, by ACE inhibitors. Now, when you re-establish the flow to the abdominal vessels by a coarctation repair, you will end up with a gut overperfusion syndrome, and that can lead to gut distension, abdominal pain, transient NEC type pictures. Of course, in adult it will end up with the acute abdomen kind of thing. So it takes some time. With conservative management, mostly settles down. As I told you, chylothorax, because of the injury to the thoracic duct, can happen early or late. Now it's important for all of us to know that the blood supply to the spinal cord comes from the spinal artery. This is the spinal artery, and a minor supply is from the Adam-Quage artery. So when you are doing a coarctation repair, especially in adult, and you are trying to clamp the aorta proximal and distal, sufficient care should be taken to take care of the spinal cord below. So that means one should be sure that you are not landing up in hypothermia, which will predispose more to neurological complication, or especially paraplegia or spinal cord ischemia. So neurological complications, it is reported in 2 to 3% of the over clinical presentations. But when you do MRI, say for example you do MRI in cases who have undergone surgery for coarctation, then you see white matter issues which are not normal in almost 60% of the cases by MRI. The patients are asymptomatic. Now, the whole CNS problem in coarctation is on the assumption that the circle of Willis is complete. So when you land up in a clamp which is transient, so the proximal occlusion of the aortic arch, it results in transient but significant impairment of the contralateral cerebral oxygen balance. So we believe, suppose in your clamp you are kind of putting it or applying it just above the left common carotid artery, then you are depending upon the right common carotid artery to continue the supply to the brain, and assuming that the circle of Willis is normal, it will also perfuse the left side of the brain, which may not happen if the circle of Willis is not normal. So this is the situation where one can land up in a central nervous system injury after coarctation repair. Now overall outcomes, early mortality in all stages are around 2 to 10%. Survival is almost 95% at 2 years and 88% at 10 years. The incremental risk factor for death today is age, weight, and hypoplastic left heart variance. Now this is very important to see this slide. There have been lot of series of coarctation repair starting from 1940s, and what the consensus or the gist of the paper is, the acute mortality ranges from 3 to 32%, and it strongly correlates with the complexity of the associated cardiovascular lesions. The mortality in isolated coarct, what we are talking today, is almost less than 2%. However, the restenosis rate is somewhere between 3 to 41%. Now, whatever method one follows, say for example end-to-end versus subclavian flap, more or less the outcomes are same. So, but this particular graph is very important. It's important to know that the situation of these patients after repair, post-repair, when they grow up. So if one has done a repair less than 10 years of age, then the probability of these people on survival, having a good survival, or late hypertension, or no hypertension, or no recoarctation, is much better So that means if you do a job at least below 10 years, it is much better than doing a job between 10 to 20 years or more than 20 years, which is the lowest. So earlier the better. Now, before I end today, I want to go through the actual contemporary patterns of surgery outcomes of aortic coarctation. This is the analysis of Society of Thoracic Surgeons Congenital Heart Surgery database. It's very important to know when in any meeting or any textbook that we read about coarctation, we often read the historical data. We talk about an era where the surgical methods were not developed in a total finer way that happens today. So all the time the people, they quote the outcomes or complications or mortality which is historical. So this particular paper is very important to know, which is in a contemporary period. The period of repair is 2006 to 2010, and it is from the database which covers almost around 95 centers in North America, a total cohort of 5,025 patients, and I will be interested in trying to emphasize on the first group, which is isolated coarctation. They form almost 54% of this group, which is a cohort of 2,705 patients. Okay? Now, this is the reason I wanted to tell you about this particular paper. And in this 2,474 patients of group 1 or isolated coarctation, the repair was done by using end-to-end anastomosis technique in almost 33%. Extended end-to-end anastomosis, that means mobilizing it to quite a bit of the descending aorta up, resecting all the coarcted tissue along with the ductal tissue and getting it end-to-end in 56% of the cases. And in only 3.4% of the cases, subclavian flap was required. Patch aortoplasty must be in the early part of that, was done in 4.2% of the cases. Interposition graft was required in 2.8%. The other methods were using, like ascending aortic advancement, etc., was using 0.4% of the cases. So if you see this chart, it's very important to know almost 89 or 90% of the people across the major centers, 95 centers, they use the technique of end-to-end anastomosis or extended end-to-end anastomosis, and it is feasible and possible in this particular group of isolated coarctation. Now, if you look to the current day mortality of coarctation outcome, the overall mortality of coarctation, that means they are divided into 3 groups. The first group is isolated coarctation, the second group is coarctation with VSD, third group is coarctation with other complex congenital heart defects. So the overall mortality of this cohort is around 2.4%. And if you look at isolated coarctation today, the mortality in this particular group of 2,400 odd patients is 1%. That is very, very important to know. So the current day 21st century coarctation surgical outcomes are excellent, and the mortality above 1% is not going to be accepted. And if you look further into what are the reasons or what are the problems after coarctation repair, you see in this group of 2,705 patients, the in-hospital mortality is 1%. The length of stay in the hospital is just 5 days. And if there is any complications, yes, minor complications that happen in almost 25% of the patients. What are the complications? Cardiac acidosis in 1%, cardiac arrest in 0.4%, chylothorax in 2.1%, persistent pleural drainage in 1.3%, recurrent laryngeal nerve injury in 1.6%, phrenic nerve or paralyzed phrenic nerve leading to either extended CPAP support or paralyzed diaphragm requiring any plication is 0.4%. Unplanned cardiac reoperation, maybe reaspiration and stuff like that is around 1.4%. Unplanned readmission within 30 days, just 2.4%. Spinal cord injury, very important to know, is 0% across the group, even in the complex group. And mechanical ventilatory support was required in only 2.4%, and that is because of other respiratory issues. So it's very important to know the current day outcomes of coarctation repair is excellent. Now, after this brief idea of the surgical treatment, I will just take you through last few slides about what will be the approach for managing a coarctation. So, in neonates and young infants, so in neonates with critical coarctation, an infusion with prostaglandin is to be started to maintain the patency of the duct as well as the coarcted part of the aorta, which usually opens up in our experience. It should be administered until the corrective surgery can be performed. Remember, coarctation of aorta is a surgical disease. So if the plan is not to establish or open up that area, the idea of doing anything to coarctation is to resect that coarcted segment. If you do not resect out that segment, you are leaving behind the disease for life and you are trying to do anything that is going to cure the disease. So it is very important, and I re-emphasize, the coarcted segment has to get out of the body by resection. Now for patients who have heart failure, general supportive care and inotropic agents should be administered. Palliative balloon has a role for sure. So palliative balloon angioplasty should be considered and done to stabilize these critically ill patients. So you can go ahead with the balloon in neonates and infants who are very unstable, who are presented after the prostaglandin intubation, correction of acidosis and inotrope supports are started off, and in next few days one should go ahead and go for surgical correction of coarctation. And this is associated with a lower risk of reintervention compared to balloon angioplasty. I think it's important for us not to recommend a particular procedure to a patient as an alternative to another procedure. My say would be a particular patient has to be addressed as required. I personally think cardiologist doing balloon dilatation is complementary to surgeons doing surgical repair of coarctation. So the job is not finished just by dilating the coarctation. The job is finished only when the coarcted tissue is resected out of the body and thrown out, and continuity is re-established by appropriate means of either end-to-end or any other method, or even with the interposition graft, which is of idle size. Now, in older infants and young children, surgical correction has been the primary treatment of coarctation at most centers. However, there has been an increased use of balloon angioplasty in this age group. The decision between these two modalities is determined by multidisciplinary team, expertise of the center, and underlying morphology of the coarctation. Now, in 2011, as per the AHA pediatric guidelines, treatment of coarctation require surgery. So in infants and children between 4 months and 5 years of age, some of the people they prefer balloon angioplasty if the lesion is discrete and there is no evidence of arch hypoplasia. Believe me, the indication for balloon is there when the lesion is discrete, limited to a periductal area, and there is no evidence of arch hypoplasia. Now, I am talking only isolated coarctation. In the presence of complex, associated complex, say VSD or any other complex cardiac lesion, there is no question of doing anything except surgery. But in isolated coarctation, in the presence of complex coarctation anatomy, that means which indicates that there is also evidence of arch hypoplasia, the decision to use balloon angioplasty versus surgical repair has to be made on a case-to-case basis. So one can go ahead with the balloon and see what happens to the results, and then recommend surgery and go ahead with the surgery. Mind you, it's very important to accomplish the surgery before the age of 5 years in these babies, because then you get the maximum benefit of no residual hypertension or minimal hypertension lifelong. And in older children and adults, for larger patients who are weighing more than 25 kg, now after stenting has come, it has become the preferred approach in many centers. In the presence of complex coarctation anatomy like vessel tortuosity, aortic arch hypoplasia, it is important is the decision to perform a stent placement versus surgical repair has to be made on a case-to-case basis. So again, in this complex older patients weighing more than 45 kg, where obviously balloon dilatation and stenting is very easy to perform and is also indicated because you can achieve an adult size stent, but this cannot be applied in all the cases where there is a complex coarctation anatomy like vessel tortuosity or aortic arch hypoplasia. it is important and relevant to go ahead with the surgical repair. It's very important after any type of coarctation repair, whether by balloon or stenting or by surgery, it's very important to observe this patient for a long term. Remember, close observation for the presence of systemic hypertension. Imaging of the coarctation repair site by the MRI or CT is performed at interval of 5 years or less, depending upon specific anatomic finding before and after repair. In infants and younger children, echocardiography may suffice due to better acoustic windows, but what is important, some kind of imaging, definitely by echo, and if echo is not good windows, then by MRI or CT has to be done on a regular basis to know what's happening to the coarcted segment. Periodic echocardiography to be assessed for bicuspid aortic valve function, ascending aorta, and ventricular function. Cranial imaging with either MRI or CT should be performed in all patients with aortic coarctation to evaluate intracranial or berry aneurysms. There is a 10% prevalence of such aneurysm in patients with coarctation compared to 3% in general population. So remember, there is a 7% increase in the prevalence of berry aneurysm in people with coarctation. So it's important to get an MRI or CT of the brain at some point of time to exclude berry aneurysm. The role of routine exercise testing for follow-up in adult is not well established. However, it should be performed in all patients who wish to participate in competitive sports. Very important line for you cardiologists to know. So if a patient who has undergone some procedure, intervention either by balloon or stenting or by surgery for coarctation, wants to participate in competitive sports, he should undergo exercise testing before he is recommended to do that. Endocarditis prophylaxis is only indicated in patients with a past history of endocarditis. In those whose repair involves the insertion of a conduit, for 6 months after the intervention, a prosthetic material or stent is used. Now, this is very important just to again highlight you angiogram of a young patient with coarctation, which is cerebral or berry aneurysm. You can see the berry aneurysm. So, surveillance for the cranial or MRI or CT brain is to be MRI angio of the cranial vessels should be done to exclude berry aneurysm in people with coarctation. Now, remember, definitely diagnosis as must be told by Dr. Nageswara yesterday, based upon especially neonates infants purely by echo. However, when one plans to intervene, it's very essential and important and wiser to get a CT scan. So that is a current favorite for whatever, even if you are doing it in the cath lab, intervention. It's important to get a CT scan, which is very simple to do, to get a whole idea of not only the coarcted segment, the tissues, the structures around that, the collateral vessels, and the whole idea about the complex anatomy of any coarctation prior to any plan of intervention, both by cath lab interventions or by surgery. So to conclude, coarctation is a lifelong disease that affects the entire pre-coarctation arterial tree. Close follow-up and aggressive management of the complication is crucial. Future endeavors should be directed towards improving the procedural aspect and long-term morbidity and survival of this condition. One of the promising recent advances in stent technology is the development of biodegradable stent, which may offer solutions for endovascular therapy of neonatal and infant coarctations. These stents keep the coarcted segment, aortic segment open, and they dissolve over a period of months. The scaffolding left over may create a favorable ratio of the normal aortic tissue to abnormal aortic tissue, which in turn may prevent significant re-narrowing. Clinical trials are yet to show feasibility and efficacy of this technology. Thank you for your